you can start.
Okay. Can you guys see my screen, first of all?
Yes.
Perfect. Okay, first of all, thank you, Carmelo, for organizing this and facilitating for us to speak here. I'll do a quick intro of who I am, but before I start, just looking through who is doing the presentation over the last several days that you guys have here, as well as the attendees, I just want to say kudos to all the program sponsors from UBORA to EngineeringForChange and everyone who's been participant of this initiative. I think it's certainly a very relevant topic to talk about, and I say kudos to everyone also who suggested Zoom to be one of the platform for this, given that obviously we're all trying to social distance here. The other piece also, I think I'll be remiss if I don't send a great gratitude for Elizabeth Johnson, who is really our conduit for us to present here. So we are the Ethiopian COVID-19 response team, or ECRT, as we're going to be calling it to make it shorter. But ECRT actually did our presentation for Lifebox, and that was sort of our mutual connection with Elizabeth Johnson. So thank you, Elizabeth, for really keeping us on top of mind and for bringing us to speak to this audience for, again, a very relevant topic and the topic that we discussed with you and the Lifebox team before. So thanks. And then just one last piece before I really divulge into the topic here, and really for the audience. When we started this research, and certainly there's a lot of issues, but I think at times issues kind of cripple us. Really the point for this presentation is to inspire us. And as the presenter before me said, COVID has certainly given us a lot of challenges. So this is our challenges for us, among others. But I don't want people to look at the challenges and get discouraged, but really be inspired to say, what can I do and what can I bring to the table? So I want to be sure by the time everybody leaves today's presentation, that's really the key piece that we want to walk away. While we're going to be pointing out, and while the title also say challenges, our point isn't just to talk about all the challenges and don't do anything about them. Certainly we've attempted to recommend some solutions. We don't have all the answers. I definitely want to preface that we don't have all the answers. We have work to do, and I think that's what we've uncovered. So a little bit about who I am. My name is Yonathan Kebede. I've been working in the healthcare industry just a little over 11 years, actually, in various parts of the hospital industry, particularly in Dayton, Ohio. So I work currently as the Vice President of Operations for Premier Health, which is a 5-hospital system locally. And I have a responsibility for emergency and trauma services, respiratory care, radiology, and rehab services. So as you can imagine, 2 of my division, particularly the emergency and trauma center, as well as the respiratory care, which is a rather large respiratory care department, we were propelled into the COVID response initiatives right after the topic came about here for us locally, which was early in March. And so some of the topics what we're talking about here, while it's really truly focusing on the Ethiopian issues, I think the lesson learned that we can bring from all of our walks of life will definitely be certainly important. So I'll be speaking a couple examples about those as well. So I want to start what we're dealing with this image. I think this kind of, to me, encapsulates, and this picture as well as the quote encapsulates what we're dealing with today. When you look at this, and I think it's very important to address that this quote, "We are all on different ships during this storm, experiencing a very different journey," was really actually part of a rather large poem that was written about an individual's quarantine experience going through. Some people are reflecting and using this as a way to really have their own moment, where others are worried about what am I going to do today, tomorrow, and the day after to feed my family. While some people can stay on unemployment and different things where they can still get some sort of funding coming to their family, others don't have that. And that's just in developing country. And so when you take this context to, or I'm sorry, that was a developed country. And when you take that context to a developing country or low income and middle income countries, that makes it even more tougher. But I think to take it even much larger, that's at the micro level, obviously, but at the macro level of looking at this whole COVID response from the countries and how they're responding, I think this still applies to that. While everyone is dealing with COVID, on how we're responding to that, and certainly the timing and the resources are all different. As you can see in the picture, some countries have the warship and all the different engine ships and boats, and other countries like my home country, Ethiopia, is just barely managing with a paddle boat. And if you've ever been on a paddle boat during a large storm like this, it's all hands on deck, and you got to do everything you can with a paddle or anything at your disposal to really bring your boat or whatever you're doing to shore, to safe harbor. So that's really the premise of how ECRT started. We're 1,750 plus global volunteers. I'm sure that number has probably gone up since the presentation. But this was really started on March 16th as the group started seeing the numbers go up. There was one individual that actually sent out a tweet, and that ended up actually bringing about all these thousands of people from all walks of life, different background and profession, to really see what they can do to help Ethiopia in responding to this virus and this disease that's definitely taking a lot of lives. We know that the dire situation in Ethiopia is much worse if the virus ends up getting a hold of some of the hotspots and potential hotspots, depending on where you live and such. So we realized, obviously, living in a majority of the African countries living in the urban core, and also utilizing transportation, public transportation and such, we knew this was going to be a very devastating disease unless we do something about. So everyone, all 1,750 plus people came with the thought that I may not be in this field, but I have this and this, what can I do? So what you're going to see is we certainly have, obviously, the health professionals from doctors, nurses, respiratory therapists, and folks like me as well. But the majority of the folks that actually started this are folks from the IT world, folks from the marketing world, folks from architects, designers, lawyers, really from all walks of life to see what they can do. And I'm happy to say I think we've been very successful in organizing the team and mobilizing on 15 different projects, ranging from data storytelling, which is really pulling in what's going on today. I think that's the biggest piece, is we didn't even know what kind of response that we have. And so looking at the numbers from a capacity, hospital capacity, equipment, and all different things, all the way to how do we actually manufacture ventilators or different essential supplies for the healthcare workers over there. So for today's presentation, I'm really just going to focus on the medical device maintenance program and project that we started. And this was also the program that, or the project that we discussed with Elizabeth that really connected us here. So once again, thank you, Elizabeth, for looping us into this. So let me talk a little bit about who are working on this team. You know, these are, as I said before, different walks of life, people with various different experiences, as well as educational background and professional backgrounds. And as you can see here, certainly a lot of engineers from mechanical, aerospace, electrical, biomedical, certainly, but as well as also frontline people like Haftamu, who's the only respiratory therapist that works there, along with various other pulmonary professionals, as well as doctors and nurses over there as well. And I think this is key, that we didn't just do a research and took a paper and said, this is what we want to do. We actually started talking to the people that are actually taking care of patients on the front line in Ethiopia with some of the hospitals that we're partnering with, to hear what they're dealing with so that we can help them. While we know that we can really pick any issue and start working on, we wanted to ensure that whatever we're working on, it's going to truly bring about an impactful change. So that's why we have these really the frontline people as our key stakeholder and as our end user. And they're also the ones that we usually do a litmus check of, is this working out, or what do we need to do? And certainly, as I talked about before, my background here, while we've worked with our own hospital resources locally here in America, I can't really take the same concept that worked for us here and trying to apply it over there. So having those people that are really working on the ground over there, seeing these patients and also looking at the resources that they have, is really key for the success of the program. Another one is we realized, obviously, many of us are here working tirelessly to really help folks over there, but this has got to be a partnership work. This is not something that we can only solve. And so as a result of that, we've been very fortunate to find Polytech College over there. Kebede is the name. This is a very prestigious vocational school in Ethiopia that's been established since 1942. And so as you can imagine, many biomedical engineers have gone through that, but we wanted to ensure that they have everything that they need as they're working to help their front line there. And we wanted to help them with whatever that we can. So ECRT has been partnering with Kebede since our inception, and also we were very fortunate enough to start also connecting with Lifebox most recently to help us with some of their expertise and some of the other resources that we'd be able to tap into that. So this is one of our really partner that we're working with to support in Ethiopia. So what are we trying to do here? What's the problem? Clearly, as the title mentioned earlier, these are the medical maintenance, medical device maintenance challenges. But I think to encapsulate that in numbers, when we looked at, again, research is obviously very hard, depending on where you look at it and getting the current. But I think we felt very comfortable based on what we saw, that 40 to 70% of medical equipment in Ethiopia, and certainly in different regions, are broken, unusable, or they're really unfit, meaning that they're missing very important parts. And so things might be going to Ethiopia, but they're probably not in the best shape that they are to really help the cause or be able to be used. There are many reasons, and I think we're going to go through all of that, but just a couple more headlines that you probably have seen. And I think when you look at it, I talked about the timing earlier. You know, COVID hit China, then it started going in Europe, then it started coming to America. Now many of the African countries are seeing their numbers increasing. There's an important piece to talk about that, and that is at this point, and I think if you look at one of the headlines here where it says, from the New York Times, where it says, "And scramble for coronavirus supplies, rich countries push poor countries aside." That's a very important distinction there. The reason is many of the countries have already started getting these dire equipment supplies, and as their surge curve kind of increased. African countries did not have that luxury, nor did they have the funding, obviously, but even today, even if they have the funding, many countries are going to suffer because of depleted resources. That's just one of those issues that even in America, clearly, oh, we've heard, somebody's on mute. We've heard many people struggling to get PPE or very much essential life-saving equipment like ventilators. That's not because of funding. That's just because there's just not enough in the market. And so, as you can imagine, then when you add the part about funding for many of the African countries and hospitals, that's going to paint a very dire picture. But I think the one thing to also note is this, I would say, is not an issue that was caused because of COVID. I think COVID probably exposed them more than anything else, but this has been an issue for far too long. I think we're just seeing this come up to mainstream because of COVID, obviously. And so, yes, COVID has certainly put a challenge and an opportunity, but this is not something that was caused as part of that. So what are some of the contributors to this challenge? We're going to talk about, obviously there could be many, but we're going to encapsulate these into 3 buckets. Lack of really the asset management system, meaning that we don't have a lot of ways to really know what we have, where the preventative maintenance has been, and all of those things. The other one is lack of training and support. And that's just, you know, we're sending or we're purchasing or we're donating equipment from many different parts of the world, but without that training, it's just sitting there collecting dust. And then lastly, along those, both the point 1 and point 2 is the mismatch. So we get a lot of donations. There's not a lot of robust process that really is looking at to ensure that all the equipments have everything that they need. So you might be missing key components that's, again, contributing to the fact that it's not being used. I tell a lot of people it's kind of one of those things where you send a phone and you don't have the right charger, that phone is useless. So this is kind of some of the issues that we're dealing with. So let's talk about that issue in a number. 93 billion. This is, you know, if you look at this, and as I said before, please don't feel discouraged when you see where some of the things that we talk about, but I think feel encouraged or feel like this is an opportunity. And 93 billion is the dollar amount that's actually being spent, and I believe this number is just in the US, for hospital system annually that are spending on medical supplies and equipment for really because we don't know the life cycle. And so we're probably purchasing unnecessarily, or we're probably purchasing the wrong item, or we're probably overpaying for things because we don't have the right system to really ensure that we're getting the best price. And I believe the quote actually came from one of the CFOs that published in the CFO magazine for hospitals. And what they've said is hospitals, and this, again, this is just in the US, are saying 12 to 16% saving if they have the right tool. So again, that's within a country that has a very sophisticated system. So imagine the problem now to a developing country like Ethiopia, where this issue is probably much greater. Unfortunately, we also don't have the type of dollars that we're talking about here. And so we're probably overusing different things for much, much longer than their service life, which obviously has its own issues, but that's an issue here. Again, this number, I put it up for people to really look at it as a challenge for us to really see that, yes, this is a lot of dollars, but that also means that there's definitely a lot of jobs within here, but how can we make it more efficient and streamlined so that we have a better system to ensure that patients are getting the right treatment with hospital system and health system not spending so much more money here. Because at the end of the day, if we look at the macro of where we want to spend healthcare, it's truly for prevention and public health, not by the time they get to the hospital system. I think that's a failure on our part, obviously, when people do come to the hospital, but unfortunately, that is our reality. So let's go back to the lack of asset management and what does that mean? As I said before, this is the piece where we have all these equipments, but we don't know when they're last maintained. In fact, we may not even know how many of the units that we have. And so in many hospitals, and certainly in Ethiopia, we really have not found anyone really telling us that they have a strong system that really talks about what type of software, or even for like paper and pencil, even if they have anything to really show how many equipment that they have, when was that equipment last maintained, when is the last service date for it, to ensure that we're also pulling it off service if it's not being used, especially for life-sustaining things where we don't want it to fail while we have patients on it. All of those very important components are not being managed very well, and I think that contributes to probably the larger issue. Again, as I said before, we don't have all the answers, but we certainly can recommend. And I think one of the inspiring thing that we've seen is the WHO actually posted that there is actually a case study, and we'll be sending out the links here for anyone that's interested. In Ghana, 4 years after installing a asset management system, they've actually seen a considerable improvement in their health outcomes. So again, these are processes that exist in many part of the hospitals all around the world. So we just wanted to at least suggest that piece being as one of the suggestions. The second piece is the lack of training. This kind of goes hand in hand. Again, you can't bring equipment if you don't have a way to really train people to use it, as well as also for people to, when it breaks, to fix it, then that use is going to be highly limited. So we wanted to ensure that, again, anytime that we have any systems that we're sending equipment or supplies, that we're trying to equip the folks that are down there to really ensure that they know how to use it, as well as also working with Kebede, that we would have a continuous education for those people that are going to be fixing it. Once again, we've seen some encouraging case study here. This one is in Kigali in Rwanda. They've actually worked with GE Health, and they've actually gone through a pilot where they were able to show by training many of their folks over there, number of out of service equipment fell by reduced by 50%. So again, just simple training can make a big difference here. So we wanted to encourage people to do that. And again, for us, it's going to be Kebede is going to be our main solution partner with that. And then lastly, the mismatch piece. And this is a little bit hard, right? Because we have an issue here with medical equipment and device, but at the same time, we can't be choosy when somebody says, hey, we're going to donate this. So I think we've been in this dogma of we'll take whatever, but at the same time, anytime that we have a lot of those are not functioning, or as we talked about before, there's a lot of accessories that are missing. So this is a bit of a balancing act, and I don't think we've found the perfect answer for it, but this is definitely something that I'll definitely open it up to this group to see what are your thoughts and what are some of your ideas. So I'm not going to ask this right now, but if you have ideas or you've seen something that works, please write something in the chat, and we'll revisit that. And I think if I missed something at the beginning too, for anyone that feels very passionate about this work, this is really open source for us to really, anyone that's willing to join in this fight, we're willing to have you on board. So at the end, you'll have our contacts to really join us if you have something to contribute. So I'll leave those two things with you. But really the mismatch is we get a lot of these equipments and we're missing many component pieces. And what's also pretty stark is, and this is something that we saw from the NPR and WHO also really corroborated with this, is 80% of the medical equipment in developing countries really, when you look at from the overall donated piece, half of those actually may not even be working. So considering that number and what we have to do here, what we want to avoid is Africa being the dumping ground for old medical equipment, as we see here in Malawi. So how do we ensure that? Because obviously, as I said before, we don't have all the answers, and certainly in order to, I think, also have a strong biomedical department, every hospital will also need some spare parts. And so I think there's some positive to this, but ensuring that a better process for donation is probably a much better way to look at this. So while we don't have all the answers, what we've found is at least we need to be a little bit more proactive when it comes to what we're asking people to donate for us. And so as we're looking at different brands, as you can imagine, just as simple as a pulse oximeter or a patient monitor, there are thousands and thousands of features as well as different brands and things. What we're trying to do, at least for our pieces, really using this design domain specification that you can see here to really ensure that there's a success of those equipment being used as opposed to for them to end up in the dumping ground. And so we're trying to use something that really is going to be user-friendly. We are actually also doing anything that we're sending from here, we wanted to ensure that we're attaching a video for a training piece for the end users, as well as also connecting folks like Haptamoy talked about. For example, we have respiratory therapists here that are willing to help them on video, Zoom, and different platform. And so we want to make sure that we continue that with all our medical device that we're sending them, as well as also that we're helping them build. We wanted to also make sure that this is highly portable, and of course also making sure that there is a power compatibility there. And then from a design perspective, and certainly that's where a lot of our engineers are also going to help us, is making sure that they're not going to be kept in the same places that we know that many of the developed country medical equipments are going to be kept in. So we wanted to ensure that that design also really takes account into all of those pieces. So those are some of our ideas here, but like I said before, we certainly don't have all the answers. We would love to have many of you here with various expertise, resources, network that could help us, but we're really trying to help Tagwaret, who's really been a very engaged partner for us. And once again, thank you again from Lifebox that really is willing to support us on this journey, but we need all hands on deck. And so anyone that has any ideas, we're all ears. So that's the end of my presentation, and I'll take any questions.
So thank you. Thank you. I was like looking at if my microphone was put on a mute. Very nice presentation with a lot of interesting points, especially regarding the topic of open source medical devices, maintenance of these devices. I don't know if there are any questions from the audience. Also, I don't know, from Andres or other mentors that can be really interested in the topic. Otherwise, I have a lot of them. I mean, so I have the first point. I don't know if can help to start the conversation. I was wondering about consumable. So you spoke about maintenance, you spoke about like capacity building in general, and also mismatch. But what about consumable? Do you think that, I don't know, there is like a lack of local market regarding consumable?
Absolutely, Carmelo, excellent question. So I think we touched upon the main pieces. We don't even have some of the main devices, and so that's what we focused on. But consumables are actually rather large issues as well. I think the nice thing though with those is at least you can, one, there might be a little bit more, when you look at the pricing, there might be a little bit more forgiving than a ventilator per se. But at the same time, I think one of the things that we've also found is a ventilator may not be working properly or may not work at all without some of the main parts, whether you're looking at pharmaceutical, even the sedatives, which we know that I think when you look at Africa, probably about 94, 95% of pharmaceuticals are actually being imported. When we realize that some of the main sedatives that are being used on ventilator patients are actually on short supplies, even in America, we know that shortage is going to be much greater in Ethiopia. So look at viral and bacterial filters. Those are very key to ensure that healthcare workers don't get the virus. But even if we have ventilators or different devices, if we don't have those pieces, that's going to be a big issue. So yes, I think this is a big issue there. What we found though is I think we could probably still get utilizing, especially in Ethiopia, I can speak about that at least because of the conversation we've had. They seem to have a direct line with some of the Chinese distributors of manufacturing, and so they're able to get those parts there. The issue is, though, I think it goes back to the whole mismatch. We might be able to help get the main device and equipment from America, but then if you're getting consumables from China, there's a mismatch there. So I think that's, again, that we've got to create a better fit and a better way to really create a criteria to see what we're getting from where and is there a match. So that work is still something that we've got to work. And I think the bigger piece is Ministry of Health also has to play a bigger part in here. But the issue is absolutely there.
Just for probably not many of the participants know, but sometimes there is also a different way in calling the same device. So they don't have sometimes a single unique code. So another question is this: there is like a problem, according to many people, like more basic. I mean, medical devices are designed in order to live in a very well equipped hospital. But sometimes there is like a not reliable power supply, there is a lot of dust. Some authors say that, hey, we have mobile phones that are working everywhere, so why don't we apply the same standards or military standards to design medical device? What's your opinion in that? So is there something wrong, I mean, in the design of medical device, if mobile phone works and ventilator not?
Yeah, you know, that's a very, I've never heard of that analogy, but I think that clearly depicts the issue and where our priority is. So if we can standardize a simple communication tool, why can't we for a life-sustaining or life-saving tool? So I'm a big proponent of standardizing. I think there's all the organizations like the ISO and such, but I think the medical device industry in general, there's probably a huge fragmentation. And I think that goes back to the cost that we talked about earlier, the 93 billion probably plus. You know, I don't know, obviously, the standardization that is occurring at the international level, but I know each organization, and I'm doing that for our hospital here in America, is, you know, we try to at least get components that are consistent so that, one, from a purchasing perspective, that you're not going to buy many of the different power supplies and different protecting surge protectors and different kind of aspects that might be helping all that equipment. And also, I think from even just standardizing your vendor, when you buy GE versus Philips, if you buy from GE, there's a better pricing, but then also from a a training perspective, you may be able to have one or two people that are very well versed in all GE equipments. That way they can help. I think when you have various different brands and such, then you create a lot of uniqueness that really is not going to allow for that economy of scale that you can get. So I think, I can't really answer for the international work that's being done, but I'm a huge proponent of, if we can standardize some of that, I think we should start. And again, this process has not taken place before, but COVID has certainly exposed us. So this might be an opportunity to really start talking about it at G20 or other platforms to really see, is there a push for that?
Okay, thank you for your comments. Now I'm curious if there are any comment or question from the audience, especially if you have some question regarding your specific medical device that you are developing. Don't be shy.
And
I'm also
Carmelo,
stopping
while people are getting off of mute, because I'm sure everyone is competing for that button, I just sent the information for, if anyone has any question or they want to join us, we have that email address. So I hope people can take us on that.